Imagine you are monitoring a patient you placed on BiPAP a minute ago. Although the patient looks and admits to feeling better, giving you the thumbs up, alarms of various priorities sound, lights flash, alarm noises blare, and your head feels ready to explode. The two most prominent alarms are high tidal volume, or high VT, and high minute volume. Oh my goodness, the horror. Of course, you don't get tense because you know exactly what to do. You simply follow the alarm management workflow. So step 1, silence the alarm audio. And step 2, ask yourself a crucial question. Is my patient crashing or stable? Despite the alarms, your assessment shows no changes in the patient's skin color or mental status. The non-vented mask is not leaking, and the patient's breathing effort improves almost immediately. When you ask, "How are you feeling?" the patient responds with a thumbs up. The pulse ox, end tidal, heart rate, and hemodynamics are improving, confirming the patient's stability. Your patient on BiPAP remains stable despite the alarms. What should you do next? Patients on non-invasive ventilation breathe spontaneously at their chosen rate and volume. In many cases, an acutely ill patient who is newly on BiPAP will need to breathe faster and take in excess volume due to distress. Consequently, this increased effort can lead to high frequency, elevated expired minute volume, and high tidal volume alarms. Step 3 of the alarm management workflow for stable patients often involves adjusting the alarm limits. The auto button modifies all alarm limits except tidal volume and apnea time. Apnea time rarely requires adjustment. Therefore, in step 3 of the alarm management workflow, evaluate if the tidal volume limit requires modification and adjust it accordingly after pressing auto. Ongoing reassessment is critical. The 4th step in the workflow for the stable patient is continuous surveillance of peak pressures, followed by step 5, applying the dopes mnemonic to work through the causes of inappropriately high or low peak pressures. Module 6 of Mechanical Ventilation Basics examines in detail the concept of pressure. Please reference Module 6 if you need a pressure refresher. To provide a frame of reference, steps 4 and 5 of the alarm management workflow for stable patients refer to this section of the troubleshooting alarms algorithm outlined in the mechanical ventilation policy. While I will provide examples of interpreting and managing high and low airway pressure, please consult the algorithm in clinical design for specific conditions and clinical indicators. Exceedingly low peak airway pressures can mean poor gas exchange. Generally, peak pressures below 12 to 15 with signs of inadequate ventilation are worrisome. Consistently low peak airway pressures with declining physiology point to ventilator and circuit leaks and equipment problems. Troubleshoot the situation by applying the dopes mnemonic. Typically, peak pressures over 30 centimeters of water in adults are considered elevated. Persistently high peak pressures can lead to barotrauma. However, certain manageable conditions may cause increased peak airway pressures. Therefore, if the peak pressure is high, consider why this is the case. It's a return to the fundamentals. Look at the patient, endotracheal tube, and breathing circuit as you apply the dopes mnemonic. This may involve treating bronchoconstriction, sedating a patient fighting the ventilator, or correcting issues with the endotracheal tube, such as depth of insertion, kinking, and mucus plugging. So to review, For the stable patient with alarms, step 1, silence the audio. Step 2, ask a crucial question: is my patient crashing or stable? The patient is stable with alarms, so in step 3, we tap the auto button and manually change applicable alarm limits. In step 4, continuous surveillance of peak pressures and the patient. And in step 5, apply the dopes mnemonic to address any identifiable causes and reassess. Sometimes the solution for the stable patient is just to modify the alarm limits. Let's take a minute to review some specific alarms. Low oxygen alarm. This high priority alarm triggers when the delivered oxygen concentration is 5% below the intended amount, typically due to equipment issues. To prevent this, thoroughly check all equipment before connecting the patient. Ensure tight connections on the ventilator circuit, green hose, and oxygen regulator, and confirm that the oxygen cylinder is full with the valve fully open. If the alarm sounds, follow the alarm management workflow. 1. Silence the audio. 2. Is the patient crashing or stable? There is no cyanosis and all physiological parameters are normal. The patient is stable. Here are some specific fixes for the low O2 alarm. Inspect for leaks and tighten the oxygen regulator, green hose, and tank connections. Next, fully open the tank valve. Reattach the quick connection to ensure it is properly engaged. And then finally, use an alternate oxygen source if tank pressure is low. Let's imagine you are mechanically ventilating an older adult with asthma and kyphoscoliosis. You get the following alarm: ASV cannot meet target. This situation occurs when the user-defined percent minute volume cannot be delivered, often due to lung protective guidelines governing ASV. This alarm occurs mainly in patients with tight lungs for which ASV attempts to limit pressure. Adjusting alarm limits provides ASV with greater flexibility in pressure and volume. Follow the alarm management workflow. 1. Silence the alarms. 2. Ask yourself if the patient is crashing or stable by evaluating the patient for cyanosis, any changes in condition, and adequate oxygenation and ventilation. In this case, the patient is stable. In step 3, tap the auto button for this specific alarm. Increasing the P limit to a value above the current peak pressure will automatically adjust the high pressure alarm limit and clear the alarm. Step 4, continuously surveil the peak pressures and the patient. Step 5, apply the dopes mnemonic to address any identifiable causes and reassess. Proper positioning should be maintained with the head elevated at least 20 to 30 degrees to minimize musculoskeletal factors that contribute to high pulmonary pressure. Address bronchoconstriction and patient agitation as necessary. Check for kinking of the ET tube and mucus plugging, which are common issues. Adjusting the P limit is common for patients with stiff lungs and elevated airway pressures on ASV. Tap the alarm banner to access possible solutions. Module 9 of Mechanical Ventilation Basics covers a standardized alarm management workflow for both crashing and stable patients. It emphasizes real-world application over theoretical lists, focusing on patient safety and the critical need to master fundamentals. The alarm management process involves promptly silencing the alarm, assessing the patient's status and following specific protocols for crashing and stable patients, using tools like the Dopes mnemonic for troubleshooting. Staying vigilant and addressing ventilator settings before issues arise is paramount to ensuring optimal patient outcomes and reducing potential complications.